Good evening to all of you from around the world. It's a true pleasure for me to introduce Dr. Athmaja Thottungal. She's a consultant in anesthesia and pain management at Kent and Canterbury Hospital within the East Kent University Foundation and HS Trust, specializing in regional anesthesia, pain medicine, neuromodulation, and medical education. International recognized educator, in 2024, she received the Recognition of Education in Pain Medicine Award from the European Society of Regional Anesthesia and Pain Therapy for her outstanding contribution to medical education. In today's webinar, organized by our partner Payung, she will share practical insights on integrating neuromodulation into acute care pathways and its potential impact on patient outcomes. Feel free to submit your question using the Q&A button rather than the chat. And enjoy the session. See you later.
Good morning, good afternoon, good evening, or good night, based on which part of the world you are joining in. Namaskaram. And I'm Dr. Athmaja Thottungal. As Bia was explaining, I'm a consultant anesthesia in pain management as well as regional anesthesia at Kent and Canterbury Hospital. It is such an honor and privilege to talk to you today regarding the neuromodulation in acute pain setting. The topic is whether it is true or is it just a fallacy. And I would like to thank Payung for giving this opportunity in association with the ESRA to talk to you regarding this. These are my disclosures. And I'm part of the faculty and the examination board for the ESRA DPM and also honorary secretary of RAUK. I have received honorarium from Sonocite and Payung in the past as consultants, and it has no bearing on this today's talk. So the topics today I'm going to cover in the next 30-35 minutes. What is neuromodulation and what is neurostimulation? Current neurostimulation technique.
Sorry to cut you off. The slides aren't visible, actually. Could you share your screen again?
Okay, so let me go back again and then share the screen once again. Okay. Is that visible now?
Yes.
Yeah. Yeah. You all can see my screen?
Yes, this is perfect. Thank you.
Okay, wonderful. So going back once again, technology is good as long as it works. Okay, so the topics which I am going to cover today, what is the neuromodulation and what is the neurostimulation? Because this is most of the time used interchangeably and it can be very confusing. What are the current neurostimulation techniques rather than the neuromodulation techniques, and what is the current evidence? And most excitingly, where is the future and the newer ideas that is coming into the acute pain world? So what is neuromodulation and what is neurostimulation? So the neuromodulation is just altering the neural activity through the targeted delivery of stimulus, such as electrical stimulus or chemical agents, like the pharmacological agents that we use, or even magnet or optical energy for specific neurons in the body. This is the definition from the International Board of Neuromodulation Society. But if you are using the term neurostimulation, it is slightly different. It is specifically using electricity, and that is called a neurostimulation. All other stimulus, as I already mentioned, it can be sound or magnet as well. Is it something new that the neuromodulation is there in the main medicine at the moment? Actually, it is not. If you go back to the history, that is almost 4,000 years BC. And the modern medicine probably started using electricity in the treatment in the 1700s. The first treatment was probably using the fishes like the electric eel or the ray as a weapon to treat pain management. So it is nothing new regarding the electricity using as a method to treat pain medication. Now, the neuromodulation, when we hear the word neuromodulation, what do we normally hear? The most common ones everybody is thinking about is spinal cord stimulator, dorsal root ganglion stimulator, or intrathecal drug delivery system, or the peripheral nerve stimulator. And in acute pain world, everybody thinks, I don't know anything about this, and this is normally a chronic pain procedure, or I can't do it, or I'm not trained to do it. So in the next 25 minutes or so, what I'm going to do is I welcome to the world of electricity and how it can be used for pain management, especially taking a lot of the techniques that are already used in the chronic pain setting, how we can translate into acute pain world. So this particular article was published in the Current Opinion of Anesthesiology 2 years ago, and Harika Lagara and his team, who is a very good friend of mine, came up with this infographics, which is fantastic. Current concepts and targets for the transition of acute to chronic pain. Because as anesthesiologists in acute pain world, our concerns are how can we prevent chronification of the acute pain into chronic pain, or how to look after patients coming to the surgery with the pre-existing chronic pain. So in this one, it is a very rather complicated infographic. But in this one, if you focus on the environment, you will see two important or interesting areas. One is peripheral neuromodulation and the other one is preoperative optimization. So these are the two areas probably where we can use these techniques to make the patient outcome better. So the neuromodulation and the neurostimulation methods can be physical method, simple as the massage, heat application, cold application, breathing techniques, or psychological interventions, including mindfulness, hypnotherapy, and CBT. The pharmacological agents that we are very familiar with, which is the WHO-based analgesia ladder, that is all analgesics and also all other neuropathic medications and adjuvants that we use, like the dexamethasone or even Botox. The electrical stimulation can be broadly divided into the external stimulators as well as the internal stimulations, which can be minimally invasive or permanent implants. And the patient-specific neuromodulation is one big area that we forget about, and we do not know how to incorporate that into our clinical practice. As a lifestyle medicine physician as well, I feel this is probably the most important skill that we need to learn along with the other electrical methods as well. So I'm not going to target any pharmacological methods today because you already are experts in this one. So the peripheral neurostimulation technique using electricity, how can we divide them? It can be non-invasive, minimally invasive, or invasive, which can be permanent. So in the non-invasive category comes the very familiar TENS machine and external neuromodulators and the electromagnetic field stimulator, transauricular vagus nerve stimulator, transcervical vagus stimulator, and also PONS, which is the portable nerve stimulator, which is commonly used in stroke patients. The minimally invasive category is PENS, which is percutaneous, which goes just under the skin, or the percutaneous peripheral temporary stimulation, which is my favorite, and I will be focusing on that today more. Then pulse radiofrequency and cryotherapy, that has been used in chronic pain for many years, and that is also translated that now into acute pain world. The PNS, which is the implants, which can be used as an intermediate one, which is more invasive, but it can be in a temporary, which is like up to 60 days to 90 days, you can leave the catheter and stimulate, or in a chronic pain condition, we do permanent implants, which I am not going to address today. So what is the mechanism of action or the proposed mechanism of action for the peripheral nerve stimulation? It is basically altering the basic physiology of pain transmission. So it inhibits the descending pathway, that is increases the descending pathway stimulation, which is 5-HT, opioid, dopamine, noradrenaline and acetylcholine pathway, and also the ascending nociceptor pathway is decreased, and endocannabinoids and opioids and GABA receptors along with the glutamate and substance P are all influenced by this stimulation. So is there any contraindication to use the neuromodulatory technique? It is like a regional anesthesia or any other procedure that we do to our patients. If the patient is not willing or patient is not consenting, that is an absolute contraindication. If you are using an invasive or minimally invasive technique and the patient has got an active infection where you are going to put the needle in, that is also an absolute contraindication. But the relative contraindications are, it is based on the clinical situation and where you are using it. For example, if the patient has got an ICD, you need to be mindful about not putting the electrodes anywhere near or very close to the equipment or the spinal cord stimulator battery like that. It is like using a monopolar or bipolar cutting when the surgeons are using the tool. Pregnancy in certain areas, they suggest not to stimulate them, mainly because the safety is not proven and also people worry about premature labor. If somebody is a patient who needs MRI frequently, then try to avoid permanent implants, even semi-permanent implants, because you need to have the facility to do the MRI with the alteration in the MRI checking or the MRI setting for these patients. Some patients with the severe cardiac arrhythmias, if you are going anywhere closer to the heart, you just need to be mindful about it as well. So what are the common non-invasive ones which you can put your hands on in your clinical practice? TENS is something very simple. It is widely available. Patient can use it. You can prescribe it as well. And the one at the bottom is called a scattering technique, where the patient's the pain sensation is masked by stimulating other areas and scattering techniques is used. It's almost like a gate control theory mechanism. Then the external neuromodulators, this is available in your anesthetic room with the normal nerve stimulator, which can be attached to a external stimulator like a pen. And you can stimulate any peripheral nerve using this technique and which can give very, very good results in many patients. Electromagnetic field is predominantly used in the patients who are having plastic surgeries, and transauricular vagus nerve stimulation and transcervical vagus stimulator are coming into picture almost in acute pain more than the chronic pain now, because people are realizing its role in acute pain world as well. The transcervical seems to have a better outcome than the transauricular because the auricular branches of the vagus nerve is only 20%, but transcervical is almost like your highway. The newest machine produced by the Pying, which is the peripheral nerve stimulation specifically for neuromodulator, I'm really excited about this one because this one gives you higher frequency up to 200. Because the previous nerve stimulator, which we used in locating the nerves, it will give you 1 or 2 hertz, but this particular one is going to give us up to 200 hertz, and I will tell you why this is important. So TENS, I don't even need to tell you who this is. I mean, amazing man. But what is important is Admir has talked about the use of TENS machine from his own personal experience. This is probably one of the simplest and cheapest method that you can use in acute pain setting. So he had a rotator cuff repair, and he has written his experience in all over the social media about this. And he realized how the pain relief is, even after using Exparel for the prolongation of his regional anesthesia technique. He found the TENS machine was something that helped, along with the electromyostimulation, helped him to engage with the physiotherapy and control his pain afterwards. So what is the evidence, efficacy and safety of this BMJ article that has come up in regarding it is a meta-analysis including 381 studies of using TENS machine. And in this one, the results showed moderate certainty of evidence that pain intensity is lower immediately after the TENS compared to placebo. Now, in summary, we should say that TENS should be considered as a matter of the physical method that is useful for these patients. Now, we always think, oh, there is not much evidence. But what about using a codeine for this patient? We all know that the number needed to treat using codeine, 60 milligram is almost 17. We still prescribe it. Then why don't we even think about prescribing a TENS machine for our acute pain patients? This is external neuromodulation. So the nerve stimulator that we use in our anesthetic practice, if it can be attached to an external pen, you can use this technique. So this lady is a 86-year-old lady who came to my clinic and who was having an internal neuromodulation using the needle technique and having the blocks done every 6 to 9 months for her shoulder pain. Once she was diagnosed with the cancer, she was not able to come on a regular basis, and also I did not want to interfere with the chemotherapy and other treatments. So we chose the external neuromodulation, which will give her like a 2 to 3 months of pain relief. So this is how I do it. So I stimulate the superior trunk for her shoulder pain. I do that for 5 to 6 minutes. So it is a very simple office-based procedure that we can do. And this is the outcome of that immediately. So no local, nothing, just a simple electricity.
China, I'm going to cherish this.
And she was absolutely happy to have that till she passed away, unfortunately. And I'm grateful to her and her family for allowing me to use this video for educational purposes. So what is PMF? This is like using the electromagnetic field, which reduces the swelling and promotes the healing. This is again another method of neuromodulation, but it is commonly used in plastic surgery. PENS is percutaneous electrical stimulation, which goes just under the skin, and this can be used in field anesthesia and field analgesia. But the only problem with that is you need this specific machine, and it needs to be there between 20 to 30 minutes, leave it on for the analgesic effect. So this is commonly used in chronic pain setting, but if you have got access to this machine, it is something that can be used in postoperative period as well. My preferred option is peripheral nerve blocks with the percutaneous temporary stimulation. Why I use it in acute pain is because the electricity is at my fingertips. I have got access to the peripheral nerve stimulator in the anesthetic room, and also the needle which I use for regional anesthesia, which can be connected to the machine. It is all about identifying the nerve and stimulating for 5 minutes prior to doing the block. And that gives that extraordinary efficacy and prolongation of analgesia. And also patients come back to my surgeon's clinic saying that their pain relief was so much better and there is reduced incidence of persistent post-surgical pain. So here what we are doing is we are combining both the pharmacological method of neuromodulation along with the electricity, which is electrical stimulation. So what do we need? A simple nerve stimulator, which is available, and an ultrasound machine where you can place the needle closer to the nerve safely, and a needle that can be connected to the nerve stimulator. So 2 hertz, 1 to 2 hertz is the frequency that is available in the old machines. The new one, as I mentioned, it can go up to 200. So 0.3 to 0.5 milliampere current is enough for sensory stimulation. If you go upon the current, they get myostimulation. It can be used for electromyostimulation, which is helpful for physiotherapy afterwards. And it improves the muscle function as well. But you don't really need to do that for sensory stimulation. 1 millisecond is the pulse width. Set it on the machine, and I do it for 5 to 6 machines. What is interesting is this is very similar to the same method or the parameters that we set up in pulse radiofrequency machine. So you do need a expensive pulse machine or the specialist needle to deliver the electricity to the nerve as you are doing the pulse radio innervation. So what is the difference between the low frequency and the high frequency? So the low frequency is below 10 hertz and the high frequency is more than 80 hertz. So the stimulation pathways, the low frequency stimulation is A delta fibers and the hyperpolarization of the C fibers, but the high frequency is A beta stimulation and hyperpolarization of the C fibers. The mechanism is said to be the endorphin release in the low frequency, and it is so evident in clinics as well because the patients, awake patients, say they feel sleepy and feel good because of the endorphin release. And the high frequency blocks the pain signals at the spinal cord level. What is best for the low frequency is predominantly used in chronic pain as well as the deep muscle pain and the trigger points. But by no means we are saying that you cannot use in acute pain setting. Majority of the acute pain patients, especially joint replacements patients coming into your theater, are chronic pain patients. So this technique using the available nerve stimulator is equally applicable as well. But if you have got access to high frequency, that may be more better for you in acute pain setting and post-surgical pain and also neuropathic pain. The sensation that patients feel is like a rhythmic tapping that you are having as a pulsing with the muscle twitch if you increase the current. But with the high frequency, it is much more and continuous buzzing sensation. But you can do burst stimulation as well, where you can combine the best of both worlds, which is the low frequency as well as the high frequency alternating, where you can treat both the chronic pain component as well as the acute pain component. So how do I do it? So this is a chronic pain patient with the shoulder pain again.
Right arm, darling. Now.
Yeah, it's actually hurting just
lying there.
Yeah. It's just hurting it. Yeah, I don't want to move.
That's you can see this lady was a high complex case, and she did not want to proceed with the surgery because of the complexity and the medical complications. And her pain is like she does not even have 30-degree abduction. So what I did is here stimulating the superior trunk again.
Okay, so you see the stimulation on the top of your shoulder, the arm as well, or no?
I feel it in the arm, not
Yeah.
It's gone up a little bit.
Yeah. Is it covering the whole area of your shoulder?
No, not. No. Oh,
That's the shoulder. Okay,
Yeah.
wonderful. Okay, so we'll do this for 5 minutes.
So the patient will guide you whether we are covering the area that is normally painful for the patient. And I normally stimulate it for 5 minutes, and they immediately after the stimulation, I give 0.5 ml of local anesthetic to the pain patients, 4 or 5 ml of local anesthesia for even a reverse shoulder surgery. And this patient, immediately after the local anesthetic, this is what they do.
Come for me. Touch your head for me.
That's amazing.
Did you see that? Okay. Can I just ask you to sit upright for me, dear? Now, touch your.
And this can be life-changing for many patients.
Try to reach. That's it. Yeah? That's it.
So from 30-degree abduction, she moved to almost full range of movements. So analgesia was fantastic, and she never came back because she continued with the physiotherapy and managed her pain better. So we did this as an oral presentation in last ESRA meeting, where we did a retrospective analysis of the patients, comparing 30 patients from neurostimulation with the low volume superior trunk block, that is 4 to 5 ml of local anesthetic, and with the conventional high volume endoscalene or superior trunk block using 10 to 40 ml of local anesthesia. And in this one, you can see the pain score, which is the blue is the neuromodulation group, and the orange is the non-neuromodulatory conventional method. And you can see the requirement of opioid and the pain score for 24 hours, because all my patients goes home after 24 hours after replacement. And you can see how significant it is, and better outcome as well as analgesia with but added with the neuromodulation. So there are few other papers that I have published, and these are the QR codes for this, both from the chronic pain world as well as in the transitional pain, acute pain world as well. So the next neuromodulatory technique that I am going to talk about is the pulse radiofrequency neurostimulation for acute pain. As we know, the radiofrequency is burning the nerve completely, but this is pulse radiofrequency, which is not burning the nerve, but changing the neural conduction. And this can be used in any kind of peripheral nerve stimulation, and we use it in chronic pain. But recently, what they have started doing is, in knee pain, you do the nerve stimulation prior to the surgery and treat the neuropathic component of the pain so that the persistent pain after the surgery and the pain score after the knee replacement is much reduced. And this is one area that is exploding at the moment. There are a lot of studies, they have been registered if you go and search about the trials book. And this is something that is going to be exciting that can use it in acute pain world as well. Cryoneurolysis is the next one, which is instead of the heat, we use cold. So you produce an ice ball and you freeze the nerve. The difference here is when you use minus 70 degree and produce an ice ball on the top of the nerve, you are basically reversibly destroying the axon called the Valerian degeneration. So you are not actually killing the nerve. The sheath will regenerate after 3 to 6 months, and the pain may come back, or the pain is like completely cured by that time. So this again another very useful technique prior to the surgery or even afterwards after the surgery in persistent post-surgical pain patients. And this is again handheld device. If you have access, it is something that is useful. Now in a pain world, the rib fractures and the intercostal nerves that has been, this technique has been used in the rib fractures. And also after the thoracic surgery, the surgeons are using it as a cryoneurolysis because they can see the intercostal nerve straight away. My only warning about this one is when you use this technique on mixed nerves, you need to be mindful this can cause muscle paralysis as well. And this is going to last for at least 3 to 6 months. So you need to be very careful which nerve you are selecting for cryoneurolysis. General nerves are fantastic because they are purely sensitive. Or a peng block or the articular branches of the hip, fantastic. Articular branches of the shoulder, fantastic, because they are not going to cause a lot of motor weakness there, and it is okay to use. You will not be using this as a technique for your femoral nerve or a sciatic acute pain setting for the knee surgery because that can cause motor weakness. So these are some of the papers where you can see where the cryoneurolysis is used in different clinical setting, including acute pain setting. So what is the current evidence? So this is a review, systematic review, where they have done all type of different neuromodulatory techniques. And it is a mixture of both acute and chronic pain. And obviously, there is more evidence in chronic pain. Acute pain world is just taking over. So I'm sure very soon we will have more research and more evidence to say that, yes, this is safe and it is more useful in acute pain setting as well. So where are we going next? Newer and future ideas. There are few exciting things happening. So this is one of them. This is a percutaneous device enabling both local anesthetic as well as stimulation, where you can combine best of both worlds, the pharmacological neuromodulation and electric neurostimulation. And Dr. Sanjay K. Sinha, he's an amazing guy he designed this particular one, and early studies are showing very good results, and hopefully we will have this one available in our part of the world as well. Currently, it is available only in USA. But this can be something that can be life-changing for many patients because you can leave it on after a surgery and you can stimulate either using nerve stimulation technique, or if you want to top it up with a local anesthetic, you can do both through the same catheter. The next one is about the RF stimulation for acute pain. So Dr. Stewart, and he is one of the consultants who is involved in the research field regarding this. So instead of the radio frequency as an ablation technique, you use a high frequency RF stimulation closer to the nerve as a stimulatory technique rather than burning it. And this has shown to give long-lasting pain relief, and the early research data is showing fantastic results. Again, he has shown that in the total knee arthroplasty, and there are a lot of studies coming up as well. So watch this space. So this is all invasive, and we all don't have access to these all advanced invasive technique. But there are so many non-invasive modulatory techniques that we can use in our day-to-day practice, which is cheap, and we don't need any other equipment for this one. So the non-invasive methods that we can use for pain management is about the patient themselves. So one is improving the gut microbiome, then stimulating the vagus nerve, and also the reducing the gut inflammation and the systemic inflammation through that. I will be going into details of each one in the next few slides. So why vagus nerve stimulation? If you ask me which nerve is my favorite in the human body, I would say vagus nerve. Vagus nerve is the best nerve to stimulate in the human body. Why? Because if you want to give a whole body sympathetic block, you have to stimulate the vagus nerve. Because you know that the sympathetic and parasympathetic autonomic nervous system and the sympathetic overdrive is producing the cortisol, and it is probably the mother of all diseases. All the inflammatory process happening because of the sympathetic overdrive. And counteracting that is the vagus nerve stimulation, which is your parasympathetic, which is rest and digest and heal. So out of all the parasympathetic nerves, probably the vagus nerve is almost 70% of the PNS. And 80% of that fibers is afferent sensory and only 20% is different. So if you can block it, you can actually obtain almost 80% of the afferent sensory fibers. No wonder why the vagus nerve is like a target for neuromodulation in the current world. As I always say, this is the master switch of our homeostasis. Because the vagus nerve controls the psycho-neuro-immuno-inflammatory and endocrine axis. So you can imagine everything that is related to the chronic pain development as well as very poor pain control related to all these imbalances that you can see. So how do we stimulate the vagus nerve? Again, it can be non-invasive or invasive. Invasive is normally done in uncontrolled epilepsy, uncontrolled arthritic patients, or even psychotic disorders. It is invasively done. I'm not going to talk about that because it is a completely different route and we don't have access to those here. Let us focus on the non-invasive one. The non-invasive one can be used by the manual and the physiological methods, and also the external stimulators, which I already mentioned briefly. So what are the 6 ways to stimulate? Mind-body connection or the mindfulness is one of them. Loving and being laughed at, or using laughter as a method to stimulate your own body. Nutrition and supplements is another one. And the device that we use, and also the breathing techniques, and certain things like a cold shower or being in the cold water exposed to cold, this all stimulates your vagus nerve. So the non-invasive vagus nerve stimulator, which are commercially available, are mainly transauricular stimulator, which is like almost like a hearing aid. You can wear it over your ear and it stimulates the concha area, which is 20% of the vagus nerve fibers. But this is like only, as I mentioned, 20%. If you can use it in the cervical region next to your carotid, which is the highway, vagus nerve in there, just between your internal jugular and the carotid is the vagus nerve. So that is the whole point of carotid massage, to ablate your cardiac arrhythmias. So you can stimulate it by external stimulator, which gives a better outcome. Or simple breath techniques, because the diaphragm and the cardiac fibers and the lung fibers are richly innervated. Even humming, because your recurrent laryngeal nerve and inferior laryngeal nerve are the direct branches of your vagus nerve. That is why the humming and cold water gargling all stimulate your vagus nerve. So what are the potential mechanism of the vagus nerve stimulation that helps in acute pain? Because it is, as I mentioned, it is a potent anti-inflammatory. And also it modulates the neurotransmitters causing the pain experience and enhances the neural plasticity, where you can change the synaptic plasticity. And also the regulation of the brain network, especially the limbic system, which is the emotional component of your pain, as well as your amygdala. And that is the main one, which is controlling your prefrontal gyrus as well as anterior cingulate gyrus, which are the 2 main areas where the chronic pain experience is there, which is connected to your limbic system. So where can we use the vagus nerve stimulator? You can use it in the preoperative period, especially if the patient has known to have anxiety, depression, and sleep issues. And also the pre-immuno adaptation, you can use it as well. During the intraoperative period, you can use it as an adjuvant to your analgesia as well as your anesthesia, and also protecting the organ, because it neuroinflammatory pathway, that is. And also your HRV and your hemodynamic stability is way much better. And in the postoperative period, you can use it for pain management and to treat the ileus, which is a big problem after the surgery, and also cognitive improvement. Again, we can use it as a transauricular and also the transcervical and also the closed loop system where the HRV feed back into the system and then adapt the stimulation technique. This is also commercially available now. So VNS in acute pain, this is a randomized control trial which was published in British Journal of Anesthesia, where they did a preoperative stimulation of the vagus nerve, and then they looked at perioperative pain score. And what has shown is it has significantly reduced the opioid requirement pain score as well as well-being of the patients. This is another study which is regarding the total knee arthroplasty, which is a randomized double-master sham-controlled pilot study done by Brian M. Field and et al. In USA, which is again transauricular vagus nerve stimulation done. And what is interesting here is what they have done is they looked at not only the postoperative pain score and opioid, but all the secondary outcomes of all domains of DPI after a week. It is the British Pain Inventory. So their emotional well-being, their sleep, medication reduction, everything comes under the BPA as well. So what it has shown is even after stopping the stimulation, the efficacy of or the analgesic effect of the auricular vagus nerve stimulation continued even beyond 1 week. So these are other two studies which I want to bring your attention into. One is opioid withdrawal, and you can use it as a method to reduce the pain after the opioid withdrawal, and also sympathetic response and stress in post-traumatic stress disorder that we see as a pre-existing condition for the patients coming into the acute pain world. So these are different studies showing these areas we can use the vagus nerve stimulation as a method rather than depending on just opioid, which is not helpful. So this is a systematic review and meta-analysis which was published in the Pain Therapy recently, which was like a year ago, where the clinical auricular vagus nerve stimulation in chronic pain and acute pain was done. Now, as you imagine, yes, most of the evidence is currently in the chronic pain world, but the acute pain world is catching up. And you can hopefully see where these methods can be used in the acute pain world as well. So this particular report was, or the article came in as a chronic post-surgical pain about the incidence, risk factors, and preventive options by D.C. Rosenberger and et al. I love this infographics because this clearly tells us whether you give GA, whether you give regional anesthesia, whether you use opioids, they are not really the major factors which will predict the outcome after the surgery. Of course, they are important, but the inner circle are the most important factors it has got effect on the persistent post-surgical pain and chronification. So we play a very limited role actually, but as anesthetists, we have a major role here when we target our focus to something else. One is patient factors, which is mainly their lifestyle factors. The other one is the pain management, which is treating the pre-existing pain, which is the chronic pain existing, and also severe acute pain and also the transitional pain, which can be preventing the chronification and the chronic pain development later. So why we are interested in this one? This is from the Center of Perioperative Care in UK, and they have given the perioperative top 7 interventions, what can change, which can change the trajectory of these patients. And if you look at them, they are lifestyle factors. We do not pay enough attention to modulate these ones prior to the surgery. So if you expand the patient factors and the pain factors into this pyramid, you will be able to see the non-modifiable factors, modifiable factors, and modifiable minor factors. I disagree with the non-modifiable factor sex in that, because sex and gender, of course, that is not that is something that can be modified, but we need to modify the methods that we use based on the sex and gender differences, because the pain experience is different based on sex and gender. And I have done a lecture for the World ESRA Day in January. And if you are interested to know more about this, sex and gender differences in pain, the lecture is already recorded. It is available in the ESRA website as well. And there is a huge difference between the male and female pain experience, pain transmission, and pain treatment options that should be available. But the major modifiable factors are probably common for everybody. Whether it is male or female, it doesn't matter. And also the minor factors. But the non-modifiable factor, what they say, is something I would argue is modifiable, especially the sex. So there is a big difference in perception of pain among women and men by the professionals. There are many studies to show that the same pain score given by a man is treated very seriously, but a woman, we have this unconscious bias which is leading to delayed diagnosis and adequate treatment. Women's physiology is different to man's physiology, and the hormones especially. Once man is attaining puberty, till they have the decline in the androgen level, which is late 60s, they do not have a huge variation. But a female goes through cyclical changes on a monthly basis as well as the different stages of her life. That includes the puberty, the pregnancy, the perimenopause, and also the pelvic pain or the pelvic pathologies like the endometriosis, which is hormone dependent, and also the polycystic ovaries, which is now known as the polymetabolic dysfunction, which is the main reason, including the insulin resistance, which affects the pain and the pain experience. So we need to think even in the which part of the cycle the female is when we are treating their pain, because in the estrogen or the first part of their cycle they experience less pain, and in the progesterone part of the cycle they have got more neuroinflammation and they metabolize medication differently, they experience more pain. And the sexual bias in medical research is really shocking as well. Most of this, even animal models, are done in male. And the human model is 70 kilo average Caucasian male. That is the default research. Until mid-90s, it was not even mandatory that a female should be included in the research. So even the dosages of the medication that we use in WHO analgesia ladder is researched in men and just translated into female, saying women are probably small men. We are not. And the paradox is females need 20 to 30% or 30 to 40% higher doses of opioid for analgesia, which is never honored in our clinical practice. This is why we need to focus on more female research and the population to have this one, and how the neuromodulation is happening even with the pharmacological agents. So the next one is non-procedure neuromodulation based on your lifestyle and the gut microbiome, because I cannot stop this lecture without mentioning about the lifestyle interventions, because becoming a lifestyle physician changed my perspective about how I treat my patients both in acute and chronic pain world. So the gut-brain axis and the pain is hugely connected. If you have got an inflamed gut, which is controlling your immune pathway, endocrine, and the neural pathway, that affects your brain, and the brain is controlling the gut through the vagus nerve as well as your PNS, which is the HPA axis, and the ENS, which is the enteric nervous system. This bidirectional control is probably very important for the pain as well as pain experience and chronification of pain. So the gut and the interconnection between the gut and the gut microbiome and the pain is multifactorial, as I mentioned, which is the gut specific organ axis exist, and gut and neuronal inflammation pathway is there, and a specific type of pain are linked with specific type of diversity lacking in the gut microbial flora. And also the gender difference exists between the gut microbiome and how hormones affect the gut microbial diversity as well. So it controls the peripheral sensitization, central sensitization, and immunoneuromodulation, which are all primary reasons for the chronification. And that is one reason why women get more chronic pain conditions as well. Even as regional anesthetists in acute pain world, we need to think, we need to personalize our regional technique. This is not about adding another milligram of dexamethasone to prolong the analgesia for another 4 hours. This is about how we can make the analgesia lasting much longer beyond that 24 to 36 hours, and how we can change the trajectory of the patient recovery and chronification of the pain. So we wrote an article, myself, Steve Covens and Sarah Caesar, we wrote an article about enhanced regional anesthesia in pain management. We should think about ERAP rather than saying the enhanced recovery, which is not even giving enough attention to the pain management and modulation of the pain. So we consider we should include all these factors, which is the patient factors, which are very important, how we can modulate the pain pathway using various techniques, which is true multimodal analgesia, then your gut microbial diversity, and it is there in the inflammatory pain as well as neuropathic pain development. The microbiota can control how much neuroinflammation happens as well. And the pain upper limb surgery and the peripheral nerve block is associated with your gut microbiome composition. Have you ever thought you did the perfect block for every patient? Why some patients has got a better analgesia lasting longer, some people don't? This is the individualization, because their individuality is determined by the gut microbiome. So the gut microbial diversity plays a huge role where you treat the patients and how much outcome you can get from the patient by doing your block. So if you amalgamate all these which I talked about today, the pain management principle, we need to look at the transduction, which is at the periphery, transmission through the nerves into the spinal cord and the central nervous system where the modulation happens, and the perception in the brain, which is your limbic system and the cortex. You can modulate at the every stage of that pain transmission using not only the medication that use in the WHO ladder, analgesic ladder, but also regional anesthesia technique and adding the neuromodulatory technique to the peripheral nerve stimulation, we can change their trajectory. And the patient factors or the patient lifestyle factors are equally important, and they help to have the better neuromodulation affecting their outcome as well. Is it all just a theory? Not really. This article came in BMJ last year. So they looked at 186 RCTs and more than 15,000 patient data, looking at the efficacy of prehabilitation and interventions along with their components, how it affects the outcome. And this is a systemic review and the meta-analysis of all the randomized control trials. So this is a heat diagram on your right-hand side. As you can see, the outcome that we are looking at are complication, length of stay, quality of life, as well as recovery. UC is the usual care. If you are giving usual care, everything is in orange or red. But if you add your lifestyle factors, which is on your right-hand side, whether you add exercise, which is activity, your nutrition, your sleep, your stress management, you can see the outcome is going into the green zone, even up to 97% in many patients. So it is extremely important to add all these multifactorial things into the patient care to modulate the nerves at every possible way to have the best outcome. So as take-home message, I would say, neuromodulatory methods, especially the neurostimulation, is underutilized, but it is an important aspect of pain management. Simple neurostimulation methods in our day-to-day clinical practice. Just be open to it and think beyond that this is only for chronic pain setting. The vagus nerve is the master switch, and it influences the gut microbiome and the neuroinflammation as well. So the vagus nerve stimulation by external or even simple physiological methods can be very effective. Personalized and patient-centered, patient lifestyle interventions are the most important and the impactful factors in the neuromodulatory pain management paradigm. So we all need to learn this as well. So to conclude, is the neuromodulation in acute pain the truth or fallacy? The truth is still the truth, even if no one believes it. And a lie is still a lie, even if everyone believes it. We are taught to use only the WHO polypharmacy using 3 steps, which was not even meant for acute pain. And we are still continuing that. Every cell has got electricity, and every action in our body, every homeostatic action is controlled by the electricity and the neural conduction. So you can modulate it by various techniques, and that is the life-changing experience for the patient and giving the best outcome as well. With that, I would like to invite you all to come and join us for our 43rd ESRA meeting in Lisbon. I look forward to seeing you, as many of you as possible there. I would be there as well, both as lecturer as well as an examiner for the ESRA DPM. So please do come and join us. Thank you for listening, and it is time for taking the questions.
Thank you very much, Athmaja, for this great presentation. Very nice. I learned a lot of things. And we have a few questions. Okay, the first one is role of stimulator for quadriplegia.
Quadriplegia. Yes. Actually, the neuromyostimulation techniques are used by both the rehabilitation teams for years, and still using. And also, I have used in quadriplegia patients in certain conditions, like for example, even after stroke, the commonest pain they experience is in the shoulder. They get severe shoulder pain, 80% incidence. So I do neuromodulatory techniques for those patients, and it is very helpful, at least to relax the muscles, so they can get more help with the rehabilitation of the muscles as well. So yes, and there are stimulators that has been used to treat, like a central implants that has been used in quadriplegia patients. But I don't have much experience because I do not work in a neurosurgical center, but I know that it has been used in some patients. Even in Parkinson's disease, severe Parkinson's disease, the deep brain stimulator is used to control the muscle spasm and the severe spasmodic pain as well.
Good. Do you use a sedation for the stimulation prior to nerve block?
No, I don't. I don't actually. So if a patient is having a general anesthesia, then I give them the general anesthesia, then do the block. But I do chronic pain patients all awake. So I don't give. I give oral analgesia. This is where the mindfulness and your care, everything matters. So being gentle with them, explaining, involving them in the care. I show them the pictures on the ultrasound screen, so they feel part of it. So I don't give. I just give local anesthesia. I don't give any sedation to the patient, specifically for the neurostimulation.
Okay, let's go to another question. By stimulating on low or high frequency, do you selectively block sensory fibers, or is there also a motor component you block?
You block it. Yeah. Okay, so this is what I was saying. 0.3 to 0.5 milliampere is the low current where you stimulate sensory fibers. But some patients, for example, shoulder, I have the patients on the motor stimulation as well, because the muscle deconditioning happens after some time. So they are not able to move the muscles as well. So I normally tell the patients, shall I dance with you? So they say, okay. So I stimulate the muscles a little bit, so they get gentle twitch, which stimulate the muscle as well. So with the muscle stimulation, you get a slightly different outcome as well. So the neuromodulation is both for the nerve as a sensory and the neuromyostimulation for the motor fibers as well. And they have got added effect. And the patients who are able to tolerate both, they get better outcome, especially the stiffness around the joint is treated by the myostimulation. Yes, I do combine the two.
How important is the option of biphasic current with the nervous stimulators? The normal stimulators only have monophasic current.
Yes, correct. So the pulse radio frequency is biphasic, as you know, but monophasic is enough to give the analgesia. And what I am trying to say is, you give nothing at the moment, but even with the monophasic, you get better results. And you may not be able to get a pulse radio frequency denervator in your clinic or in your anesthetic office. So use what is available, which is cheap as a chip, and easily you are familiar with the machine. The only thing that you need to do is keep the stimulation for 5 minutes, 5 to 6 minutes, and that will give you the outcome. And that is available, I'm really excited to use in the clinical practice, hopefully soon. I will be able to selectively increase whether I want the A beta fibers or A fibers, and you can have biphasic or monophasic depending upon what is your preference. Yes.
Okay, here we have a long message. Dear Athmaja, many thanks for your great presentation. What would be your approach to a patient with combat injury to sciatic nerve resulting in severe neuropathic pain? The nerve is damaged, trapped in scars, but motor function is preserved. Thanks.
Thank you. That's a great question. Actually, I work in a hospital, we are a major vascular center. So we do have a lot of amputation patients, and they are one of the most complex patients as well, because they have got ischemic pain, they have got neuropathic pain. Even after post surgery, they can get neuroma pain, neuropathic pain, and also phantom pain. So it is a mixed bag of complex, and the fibrosis of the sciatic nerve as well. So I will approach this in 2 or 3 different ways. Based on the scar tissue, we use a technique called hydrodissection. So actually, when you are doing a regional anesthesia technique using high volume, what you are doing is hydrodissection. So you are releasing the fibrosis around the nerve. That itself is a treatment. So the hydrodissection will help to release the nerve, but I neuromodulate prior to that. So in amputation patients, we do neuromodulation prior to the block, which helps with their pain postoperative. And also if the pain comes back, we go and do neuromodulation repeating again. Now, phantom pain, it is fascinating when you do the neuromodulation of the phantom pain patients. Patients explain to you and they say, oh, my phantom is shrinking. It is in their brain, that area of the phantom limb is shrinking. They say, oh, my toe is going, my little toe is going. And it is amazing to hear the feedback from the patient. So if you have got patients like this, I would approach both techniques and also look at the patient, because most of them may be post-traumatic stress disorder. So you need to bring their sympathetic overdrive down. This is where sympathetic block, like a stellate ganglion block, along with the vagus nerve stimulator, would help these patients to emotionally bring down their limbic system, especially the amygdala is like, it is on fire at the moment. So it will be a truly holistic approach. Sorry, Bia, you are muted.
Sorry.
Okay, I will read the question. Yeah, how many days the analgesia will last following sphere trunk stimulation? Okay, so I will tell both scenarios, acute pain and chronic pain. In chronic pain setting, even with the 0.5 ml of that local anesthetic and the nerve stimulation, when I look at the data, it lasted for months to years. There are certain group of patients who do badly. One is diabetic patients, because the diabetes is the primary problem. We need to control that. And second group of patients who had a poor outcome is the post-surgical patients because of the scarring. But in acute pain world, because it is of the things, the analgesia is definitely prolonged and the quality of analgesia better. And you need to imagine acute on chronic pain. So the efficacy is way much better for the block and the prolonged as well. And they normally go home with the maximum of 1 or 2 doses of opioid after the shoulder replacement. So I have not done hopefully I will be able to do some, and I am excited. Probably I will have a opportunity to high frequency stimulator, peripheral stimulator for those patients, and then we can see. Again, as you know, in evidence creation, you can only look at one parameter at a time. So, and it takes such a long time to set up a randomized control trial. So it is difficult. I don't have a ready answer, but this is from my clinical experience and what my surgeons give feedback to us, because we work as a team, and I always tell the patients and him as well, please give me the feedback.
Thank you very much.
The
Another
next
question. Can you
Yeah.
stimulate the vagus nerve with a cold shower?
Yes, you can actually. That is one of the simplest method to do. You want to do it yourself as well. Before you start your day, before you take a shower in the morning, so you start as a normal shower, and then what you need to do is set it up to the cold setting. And initially, it is almost like a shock. When the cold water comes on you, you will go, ha, 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 ha. As soon as your body gets set to that, you will stop that and stand there for as long as you can. Maximum is like a 2 minutes, but it comes with the practice, and you will feel different when you do. And even humming along with that stimulates your recurrent laryngeal nerve and inferior laryngeal nerve as well. So why not? And the cold water swimming is another one. Cold water plumbing is another one. But yeah, it is not for everybody, but it does definitely makes a difference in the vagus nerve stimulation.
Okay, thank you very much. Another question. I want to ask if you have experience with alcohol neurolysis for chronic pain. If so, what percentage of alcohol do you use and what are the results?
Yes, I have used alcohol, but my preference is phenol actually. So 2 reasons. Alcohol is something that can be used if you have got access to it. It is like almost like absolute alcohol that we use, or 50% alcohol, depending upon where you are putting it in and which nerves you are burning as well. My preferred method was phenol because it was something that was available locally in our hospital. So I have used both aqueous phenol as well as hyperbaric one as well. In cancer patients predominantly, or palliative patients. And depending upon where you are using, how you are using, what is your outcome that you want, if you select the patients properly, yes, it has got a very good outcome, very good outcome. But again, you need to be mindful when you are doing alcohol or phenol, you are burning the nerve. So motor fibers will be affected as well. But in a palliative patient, the patients, you don't really worry too much about it. But both are very good aids for that.
Please, what frequency do you to use in percutaneous neuromodulation?
At the moment, with the ordinary nerve stimulator that we have in the anesthetic machine is 1 or 2 hertz. So I use 2 hertz, which is the low frequency stimulation. So I am basically stimulating the A delta fibers. But if I have a higher frequency machine accessible, that can go up to 200, which will be A beta fibers predominantly. Yes.
What do you do for knee replacement? You hear me? Can you hear me? Can you hear me? What do you do for knee?
Sorry, I missed that question, Bia.
I don't get
knee replacement. Did you ask the knee replacement?
Knee replacement. Knee.
Yeah. Okay. So the knee replacement patients, if they have got a pre-existing neuropathic pain, it is always good to do the genicular nerves and a release, because the genicular nerve entrapment is one of the reasons why the patient has got neuropathic pain in the knee prior to the surgery. So that is why simple hydrodissection of the genicular nerves by genicular nerve itself in chronic pain world get fantastic results lasting 4 years. So if I'm doing acute pain knee replacement, I combine the genicular nerve blocks along with the femoral nerve block as a low concentration, which is purely sensory, and I pack at the back for the popliteal plexus as well. So that is my recipe for knee replacements.
Thank you very much. What is the risk with vagus simulation out of operate EOM?
Out of operating theater, you mean?
It's written EOOM.
Sorry, I can't, I didn't get that. But yeah, okay. What are the okay in the out of operating room? Okay. Operating room. Okay. No, this is not very risky at all. But we train the patients, and unless they have got severe bradycardia pre-existing, we need to be careful. Patient can use it as a device at home as well. So it is not like you are going into the vasovagal attack. Now, but you need to teach the patient, and also normally the auricular one is much more safer in that way rather than going for the cervical, especially elderly patients. So there is no, I mean, of course, any procedure has got side effects and the risks as well, but the risks are very low compared to what is the risk of having increased pain and uncontrolled pain in those patients.
Okay, thank you very much. Can we combine acupuncture with neurostimulation for hemiplegia after
stroke? Can we combine, yes, acupuncture with a neurostimulation? Yeah, absolutely. I mean, you know, acupuncture, electric acupuncture is a neuromodulatory technique as well. So you can definitely combine the two if you are a trained person to acupuncture. So it is not just stimulation alone or the technique alone. You need to know what you are doing. So definitely you can combine the two, and it will be beneficial to the patient.
Good, thank you. Thanks for the illuminating lesson. Thank you. What about simulation for fibromyalgia?
Yeah, as I told, the low frequency stimulation is proven to be beneficial for patients with fibromyalgia than the high frequency, mainly because it helps with the muscle as well as it is producing the endorphins, which helps with the widespread small. Many patients, when they are diagnosed with myalgia, I don't take a diagnosis. What I normally look at, especially women, when they are diagnosed with fibromyalgia in their late 30s and 40s, I look them as a perimenopausal changes, hormonal changes. And that is one of the main causes of widespread pain in women, rather than diagnosing or over-medicalizing it as a fibromyalgia. So always think outside the box, think laterally as well. If the patient has got other signs and symptoms of perimenopause or menopausal changes, treat that and you will be pleasantly surprised. Many of these fibromyalgia symptoms will go away. And also check their vitamin D and magnesium, because when women are going through menopausal changes, they do lack B12, magnesium, as well as vitamin D. And that replacement itself will reduce the widespread pain syndrome.
Okay, let's go with the two last questions. How long lasts external neurostimulation? Do you combine with lifestyle medicine and this affect lasting effect?
Yeah, that is again another fantastic question. Yes, I do external stimulation, varies patient to patient. Like that elderly lady where I did internal neuromodulation first for the shoulder, it lasted between 6 to 9 months. But the external neuromodulation was lasting between 2 to 3 months because she had some lymph nodes as well. So it was compressing on the nerves. It was not lasting longer. Some patients get a fantastic results, and it is always combined with the lifestyle changes and the physiotherapy changes in their nutrition, mindset, everything together, because that is all part of the package to help the neuromodulation.
Thank you. And the last question, what is the place of PRF,
preoperatively. Yeah, this is again, if you have got access to pulse radiofrequency, it is more specific to the pain condition, especially neuropathic pain. So if somebody has got a pre-existing pathic pain and you have got access where you have the facility pulse radiofrequency, the typical example is the genicular nerves. Genicular nerves PF or any other nerve that pain. For example, the amputation patients, you can do the PRF prior to the surgery. And it is shown that it lasts for like more than 4 weeks prior to the surgery, then they have the surgery afterwards. But again, it depends upon your setting, your clinical setting, your access to all these equipments, and which is the best candidate for which technique. But as a rule of thumb, I would say you can modulate the nerve conduction from the moment that you see the patient. That is through your conversation with them, how you reassure them, the emotional connection that you develop with the patient, reassurance, your body language. That is all giving the neuromodulatory method to them, even their vagus stimulation when they are relaxed. So from there to your all gadgets that you have access to, use them wisely, and the patients will benefit from that.
Well, the webinar has come to the end. A big thank you, Athmaja, for this wonderful presentation. A lot of compliments are coming. And thank to all of you to be online with us. Thank to Payung. And we look forward to seeing you again next month, the 23rd of June, for the next webinar organized with Payung. And thank you very much, Athmaja, for this wonderful moment together. Thank you. And goodbye to everyone.
Thank you ever so much once again, ESRA and Payung, for this opportunity. I really hope everyone is more interested in neuromodulation and serving our patients who are really in need of good pain relief all over the world. Thank you, Namaskar.
Thank you, Athmaja. Thank you
Good
very
night.
much.
Good night, everybody.
Goodbye to everybody.